Welcome to the University of Washington School of Nursing Voices of Nursing podcast, where we dive deep into the diverse and inspiring stories from the heart of healthcare. This is Voices of Nursing. Welcome, everyone. Today we're joined by Dr. Sharon Laing. We're so grateful to have Dr. Laing with us here today. And just to kick us off, Dr. Laing is a faculty member at University of Washington, Tacoma, has been since 2015, has postdoctoral fellowships from Rutgers University and University of Washington, Seattle, with accolades that include a predoctoral award from the Department of Defense Breast Cancer Medical Research Program and an American Psychological Association Dissertation Research Award. Dr. Laing's research focuses on healthcare decision-making, mammography utilization, and health services targeting cancer prevention, control, and workplace wellness. Currently, she leads a multi-site effort exploring mobile technology's potential to empower low-income communities in self-management and healthcare interactions. And most recently, Dr. Laing was the 2023 recipient of the Lyndon Haviland Public Health Mentoring Award, which is an award given annually to public health practitioners or academics who exemplify excellence in mentoring. And I also want to call out that Dr. Laing is also the recipient of the recent MLK Service Award given to folks in the health sciences who demonstrate particular contributions to community service. So we're so grateful to have you here with us today.
Well, I'm very grateful and honored to be here, Alex. I'm very much looking forward to this discussion with you.
Thank you. So let's just start talking a little bit about you and your journey and how you came to approach research from this nursing lens.
Yeah, that's quite interesting. I'm a psychologist and not a nurse, and I completed my doctoral work at Howard University in health psychology. During that work, I worked with the director of the Cancer Research Program to look at mammography screening activities for African American women. It's quite interesting how I got to that point because when I started my master's there at Howard, I was very much steeped in psychophysiological research. And in this work, we were looking at how we can assess cognitive processes, decision-making, by looking at the startle physiological response. It was quite technical and quite interesting for me to look at that. And just serendipitously, I was introduced to Lucille Adams Campbell, who was the director of the Howard University Cancer Center at the time, and she was doing some work looking at cancer screening for Black women in the South region of Washington, D.C. And at that time, I wasn't aware about the discrepancy in breast cancer screening and breast cancer outcome for Black women. And I thought, wow, here's an opportunity for me to work in the community, because she was actually engaging with women in the communities. These are women with first and second degree relatives with breast cancer. And she was, trying to engage them in screening, helping them understand the implications of engaging in screening and what does that mean for their health and wellness. And right there, I did an about turn. I switched right away from my lab, where I was doing the startle reflex activity, and moved into looking at community engaged work and working with these women to help them understand the importance of screening. And that was how I got more steeped into more health-related research. And that propelled me into the postdoctoral work that I did at Rutgers, looking at the implications of, it was just after 9/11, and we were seeing these respiratory insults for a lot of the people that were living there, particularly rich painters. And so they brought me on to help, engage and interview and assess, do cognitive assessment as well as physiological assessment of these painters. And so, it's funny how one thing led to the other. And here I am at UW Tacoma from Rutgers. I did come to Seattle, and I continued that workplace wellness type of work in the School of Public Health for a few years. And then I moved on to Tacoma, and here I am today.
And we're so glad you are.
Thank you.
And was there a particular reason why University of Washington Tacoma for you?
It's interesting because Though I was steeped in the research when I was it was the Health Promotion Research Center at the UW School of Public Health, and we were really doing some really interesting work with low-resource workplaces to support their employees around, again, healthy eating, physical activity, smoking cessation. But I also recognized that there was an opportunity available to really be impactful in the classroom. And we know that at UW Seattle, we do a lot of research here.
Yes.
But I didn't see the opportunity to do a lot of teaching in addition to research.
And that's a passion area of yours.
And that is also a passion. So it's this binary thing where I want to do research, but I do want to spend a lot of time in the classroom.
Yes.
And so I thought that, UW Tacoma is a fantastic teaching institution. It really is very student-centered in its orientation. Faculty are encouraged to develop the curricula, not only with the student in mind, but how are the students going to use that material when they leave the classroom. So it's not just about the theoretical information, but about the application of it. A lot of our students are place-bound. They're from Tacoma, so they're going to go back and use this information to lift up their communities. And so I was excited about the opportunity to teach in especially our nursing and healthcare leadership program, because of the fact that it's a dual program. We have the nursing piece, but we have the healthcare leadership piece where we want the students to go back to the local health centers in the area, and we have quite a bit of them in this area, whether it's Multicare and others. They can make a difference in these communities, especially when on our campus, must be about 60% of our students are BIPOC students. A substantial number are first in their families to go to college. They're very passionate about that work. And really, I cannot explain what a blessing it is to have these group of students in front of you to be able to help them think about how they can make a difference in their communities. And so it was an easy choice for me. So though I do my research, and I do, I'm really, I'm focused on both. I'm focused on doing the work that address community health and wellness, but I'm focused on helping to build leaders that go back to address community health and wellness as well. So it's been really quite an opportunity.
So amplifying your impact.
Yes, it really does.
Yeah.
You're right.
Love that. And your research covers a variety of areas, and I think it's important to acknowledge that your areas of research include cancer prevention and control, workplace wellness, and now the role of mobile technology in healthcare for low-income communities. So why these research areas? What drives you to have this kind of more widespread variety?
Well, the cancer prevention control came from my doctoral work, and of course that was a springboard into my doing some of the other work. The community health and wellness really is key because that's where the rubber hits the road. I don't want to be too pedestrian in how I say things, but we cannot, and I think a lot of researchers recognize that now, that we cannot just operate in a lab and just develop and cultivate and incubate this kind of tool or mechanism and say, okay, now you go and use the community and make a difference. It doesn't work that way. I'm on the UW Executive Council for the Population Health Initiative, and that is all that we are talking about lately. That we must, when we talk about community engaged work, it involves getting the community involved in the decision making, developing the ideas initially,
co-creation.
thinking about co-creation, how you're going to measure the outcome, how you're going to implement. Does it even work for your community? Is there demand for it? So if we put this in place right now in your community and we leave, is it sustainable? That's key, because many times as investigators, we develop this nice fancy things based on research. We tell folks to do it and it falls apart, and people start to lose trust in us because they say we're taking from their communities, taking all this data, and nothing is happening because 5-10 years later, they're still in the same place that they were in when we first came in. We have to engage our community, as you said, Alex, you're right, from the inception to the outcome. And even when we finish, we still have to go back and engage and find out, how is this going? What tweaks do we need to do?
Yes, the listening, the iteration, making them part of improving it.
Absolutely. And they feel, and if they're bought in that way, they're willing to continue to work on it. But if they're being told told to do this and then you leave because you got your data and you're okay. That's not cool.
It's transactional.
It's transactional, and we have to make it relational. I mean, you're so right. I love the term transactional. We cannot be transactional. It has to be meaningful. It has to engage them as well as you, and we have to build that trust so that they feel engaged. So now, though I had an interest in, and still do, in mobile health technology, that came out because I spent a brief stint at Joint-based Lewis McCord, where we were working in the National Telehealth and Technology Department. I was working as a psychologist. We had a few psychologists who were considered subject matter experts around anxiety, stress, and a number of different psychological and cognitive functions. And we're working with the developers to develop tools. And the reason that came about, that was several years ago, but it's amazing how telehealth has become so prominent now, because it wasn't at the time.
Yes.
I remember when we started, it was because of the fact that we had a lot of our guys in theater who were experiencing substantial emotional distress. Of course, they can't share that with their mates because then people get very concerned. And so the gentleman who was leading the division at the time was thinking, well, we need to develop tools so that they can communicate with their healthcare providers remotely and not have to worry about disclosing that they have these issues.
That privacy and protection built in.
Absolutely. It's essential. And this is how it started, Alex, with our guys in theater. And we developed a number of different tools. I mean, I can't remember half of them now, but we worked with them to do that. But then once I left T2, I thought, we should be doing this with civilian populations as well, because we have folks that we can't reach, whether it's rural communities.
Oh, yes.
Immobile folks.
Yes.
People with some handicap that they can't get to the physician on a regular basis. Other groups of people. We also recognize that with certain groups of people, say lower income folks, they have their smartphones. If they have nothing else, the smartphones is really key for them to make their connection. Why not leverage that? Why not leverage the smartphone to get them into the healthcare system? And so that was the impetus to start that work. And we pursued a grant to do that work. And that was where the multi-site piece came in. COVID hit, and then I changed the trajectory as always.
I think everybody kind of did at that time.
We had no choice.
It's true.
And so I've moved into other domains. But yes, that's an answer to your question.
Yeah, absolutely. And mobile is sometimes felt, I think, an afterthought in some cases. Still, to this day, we think of developing applications for, websites or desktops. But mobile is so powerful. And you're right, it is, for many people, that's their entry point to the internet. That's how they experience it. So not making it an afterthought, making it something that is at the beginning of the process of development.
Central, yeah.
And your work focuses in many cases, and I heard you talk about earlier on, the disparities of outcomes related to mammography, and that there are some clear disparities. And for our audience, I was hoping that maybe you could tell us about how you focus on the intersection of sociocultural, psychological, environmental, and patient health factors in your research. So tell us a little bit about those intersections and how that manifests.
It is quite interesting. There's quite a bit of intersection there. It becomes so complex because it's so layered. When you talk about sociocultural, then you're speaking about a way of doing things in terms of communities, and really educating communities about the importance of engagement in the healthcare system. If historically your family members have not been as engaged as they should, then you will not be as well. That sociocultural, or that cultural way of looking at things, is related to the psychological as well. I don't want to, again, overstate the importance of medical mistrust in communities of color. That's the psychological. You have communities who historically have been harmed by our healthcare system. They have been. Whether it's explicit or implicit, they experience those harms. And so they are not as, they may not be willing to go in for their wellness checks as regularly as they should. And even if they do, they may not adhere to some of the recommendations because they're not sure if these recommendations are thinking about themselves. About their best interest. I'm going to give an example. I was talking to a colleague of mine. He's from Palestine, and he was saying, Sharon, that's such an interesting point because my wife went into the hospital with, it was a gallbladder, and she had these symptoms, and they took care of it. His wife is white, and she got that taken care of. But then later on, he was experiencing similar symptoms as his wife, and he went into the hospital and he says, Doctor, I think I have a gallbladder issue. And the doctor said, no, you don't have a gallbladder issue. I know what you have. You should not tell me. That's the other problem that we have to address, that very authoritarian way of doing things. And so they gave him a number of different pills and all these things. And this went on for 2 years. 2 years. And he says after that, it started getting worse. The symptoms got much worse. And so he went into a different facility, and they're saying, what's going on? You're looking pretty darn bad. He says, I think I have a gallbladder concern because my spouse had that and I share similar symptoms. They said, okay, we'll just do the test. Just like that. They did the test, and sure enough, and they said, my gosh, why wasn't this not taken care of before? He was not listened to. And the thing is that it may or may not be a race thing, but I think that as healthcare providers, as you say, the co-creator in terms of research, we have to work with our patients as like a partner in their healthcare delivery. We have to be able to say, these folks know exactly what's going on. Let me listen. Let me check out what they say. Yes, they may not be a medical doctor, but if they have this information, let me just check it out. And so that's the mistrust that I'm talking about when people feel they're not being heard, or they've experienced a family member having some adverse effect in terms of that engagement, then they won't want to engage in the healthcare system. So that's a sociocultural and psychological. And then, you have, socioeconomic factors as well that also, and so in terms of health disparities, that can lead to health disparities if you're not engaging in the healthcare system. Because that was your initial question. How do these things intersect to impact healthcare health disparities? If you're not engaged, if you have a perception that the system is against you, then you're not going to adhere to treatment. You're not going to respond to any changes in your body the way you should. But then you have the socioeconomic, right? If you're a patient or an individual whereby for many of us the copay is nothing to think about, but for a lot of people that's kind of a huge burden for them. It's massive. And so if you feel a lump somewhere or hardness in your breast, you can just pass it off as nothing, or I just can't deal with this right now because I have all of these other economic responsibilities that I have to address with my family.
You almost don't want to know what it is.
You don't.
Then you would have to face the impact of that financially, physically.
Exactly. And so if you delay getting that diagnosed and finding out what that is, then you're looking at something that is advanced to a higher stage because it wasn't attended to earlier. That's the economic piece. So you have these layers, whether it's sociocultural, whether it's psychological, whether it's economic, whether it's physical in terms of the environment. These are the physical factors in the environment speaks for itself. You have cultures and communities who live in environments that they're exposed to environmental toxicants. The inhalants of these things can yield these poor health outcomes as well. And so that's another challenge. So there are multiple layers and it's, when we talk about intersection, as it was mentioned before, we cannot dissociate each item and just look at them individually. That's why they're called intersection. They operate together to have this additive, very global effect. How do we look at these things together to help those communities who need our help the most?
And that's a shift from an academic discipline standpoint, looking at these things holistically, systemically.
Yes, it is a shift. It is a shift. And in many ways, there are so many more things expected of us as individuals working in academia. We cannot be linear in terms of the work that we do anymore. We certainly have to be more contextual, more global, and think in these, recognize all these different partitions that's coming out, because that's the only way we're going to be. The world has become so much more complex, is what I'm saying. So that we cannot just be isolated and work in just one dimension, because we'll never solve those problems. Similarly, and that's the reason why research has evolved to become much more multidisciplinary in terms of how it moves, that you can't just work within your discipline anymore. Public health is connected to nursing, which is connected to social work, which is connected to computer science, which is connected to urban studies.
Yeah, absolutely. Well, I'm very excited to see more about what's coming out of your multi-site research that you're conducting right now. You're currently investigating the role of mobile technology in facilitating patient self-management, particularly with their interactions with the healthcare system. Could you tell us a little bit about that research?
So this research started from my work at Joint Base Lewis McCord, and I was collaborating with a local community health center, Health Point Community Health Center, to understand how we can best support patients in their healthcare access and delivery using these tools. So we started out by asking the patients about their specific needs and how we can best support them. But we also recognize that in order for patients to access their needs, we need to understand the role of care providers as well, because it's not divorced from each other. How can the care provider work with a patient who comes in with knowledge?
That's a point that you see an almost a resistance to, or an irritation by, as opposed to this sense of, oh, they have information, let me get into a posture of curiosity. Continue.
You're absolutely right. We needed to engage healthcare providers. We needed to understand what is their position around patients coming in with this tool and say, doctor, this is what I think I have. This is what's going on. How can you help me with that? It wasn't about turn that physicians and other healthcare providers needed to make, and I think that they're making it. But it was tough because that's not how you've been traditionally trained. You're traditionally trained to give information to the patient and for them to follow through. So that was something that we needed to explore, and we did explore to see the interest or the convergence of beliefs between patients and providers around how healthcare should be delivered when you have information that's out there and is accessible to the patients. Now what we're doing, I've shifted a little bit in terms of this work in looking at how we can support providers so they can best support their patients. How did this come about? You may be aware of this, Alex. Back in 2020, there was a doctor, Dr. Lorna Breen, who died by suicide in 2020. She was an emergency room doctor in New York. And the issue there was that she was putting in hours upon hours and hours in the nursing room during COVID. She didn't take the break that she needed, and she was experiencing some mental health concerns, depression, anxiety. But here's the issue with some of our physicians. Their licensure is contingent upon their indicating emotional well-being. They ask those questions. So you cannot admit that you're experiencing depression, certainly substantial depression, within a certain span of time. Dr. Breen may not have disclosed that, and she was experiencing that, and yet she was pulling in all these hours, and she was burnt out. So she had the emotional insult plus the physical insult and burnout, and she couldn't handle it. So back in 2022, the Democratic Party, the Biden administration passed the Lorna Breen Mental Health Act that's designed to be able to intervene, at least investigate what's happening with physicians around burnout, workload, suicidality, mental health, physical health, because it's not just something that happened during the pandemic. That was going on before the pandemic. It just got exacerbated by the situation, and there's work to be done. So my research team and I are looking at that. We're working with various, and the reason why we chose community health centers, because this is happening in multiple healthcare settings, But the reason why we chose community health centers is was really intentional, because our community health centers are working with patients that are experiencing some of the most dire conditions, right? And they're also patients like new immigrants and patients that have some kind of heavy socioeconomic challenges, and some challenges. One community center that we're working with is working with homeless transgender patients. This is a group that we have to reach.
Highly underserved communities.
People with insistent and persistent substance use and abuse issues. We have to and they're homeless. We have to reach these folks. So my thing is that if we're not helping our healthcare providers, how are we able to then help their patients? Because the healthcare providers are not able to help their patients if they're not feeling well served as well. So we decided that we're going to go at this differently. We want to help the healthcare providers for themselves, but ultimately, indirectly, that will help the patients. So we've just started this work we're using a recent national data that has investigated the well-being of healthcare providers in community health centers. We've analyzed the data. We're pursuing funding for that, and we have our partners, our community health centers partners, and we're going to, explore these interventions to support our healthcare providers and ultimately support our patients.
So you're shedding light on a much deeper issue that will have tremendous impact for outcomes for patients. I appreciate so much the story that you told about Florida, because when you think about how our society, when you think about systems and how they can incentivize or de-incentivize people to care for themselves, that is an example of how the system itself de-incentivizes caregivers and physicians from caring for themselves, because to admit that is potentially to endanger your profession and your livelihood and your source of fulfillment. So why would you? And those aren't the only disciplines or the only professions in this country that we do that in.
Yes.
But how do we flip that script and incentivize people and how do we truly make them safe? Not just make them feel safe, but how do we truly make them safe with systems change, with policy change to support them being honest about how they're feeling?
The one thing you are so right on, spot on with that, Alex. The one thing that I'd like to share is that as we were looking at the national level data, looking at burnout among our direct clinical service providers in community health centers, we found 3 factors that predict burnout. It was workload. I understood that. I wasn't surprised. It was work-life balance. Not surprised about that. The third one was professional growth. I looked at my my colleague who's analyzing the data, and I said, professional growth, that's a good thing if you're giving opportunities to be, and that was defined as engage in challenging tasks and do things that uplift your career. Why would that add to burnout? Well, here's the switch. The more you're going out doing all this extra stuff, even though it's supposed to be good for you, you're not able to get your normal day-to-day work done. You come back and you feel overwhelmed even more than when you went out because of the fact that all this stuff is piled out while you're out there getting all this extra training.
You're being so supported to go out and develop yourself, but there's no backfill. It's still there when you get back.
Okay, now.
Yeah.
That's it.
So stressful.
So then supervisors may think they're doing the greatest thing, and you appreciate it initially.
Right. The intent is there.
The intent is there. Until you came back and you think, oh my God, my desk looks like this. I can't see above.
Yes.
The stuff.
Yes.
And so this is where I think that the dissemination of that information to healthcare managers and leaders and supervisors will be key for them to really reconceptualize how we best support the people on the ground working with the patients.
Yes.
It's nice to give them these opportunities for growth, but how does it look and how does it work in terms of their current work and getting that done?
Because they're only humans. There's unintended consequences the more and more and more you give folks.
Yes.
Even good stuff.
Even good stuff. So it's just really being intentional and thoughtful about how we do these things, right? And how we support folks.
Well said. So we only have a couple minutes left. So I'm going to jump to our last question, and it's a good one. So what advice would you give aspiring researchers, nurses, in your case, psychologists, who are interested in pursuing a career of research in particular?
Yeah. I think my advice would be to really look carefully about why you want to do this work. Because we know that research doesn't just start and stop. It's not, the time is not delineated, of course, we do know that. But you cannot go into research because of the physical incentives of being in there. Getting grants, publishing papers, getting known.
The prestige.
Mm-hmm. You have to recognize that, especially for health services research, you're impacting lives. And if you're impacting lives, then the project that you conceptualize, how you conceptualize the project, how you execute and implement that project needs to be very, very thoughtfully considered. It cannot be, well, I want to get this grant. I'm just going to look at their RFA and what they're asking, and I'm just going to muddle this to make sure it fits that. I would suggest that you begin with the community that you're working with, understand carefully their needs, even if you have to talk to them before you even start applying for grants, which you should. Understand what their needs are. Understand what they think might be the best way to meet their needs. And then you tailor your research proposal if you want funding for that. But don't get the RFA and then try to make the community fit into that, if that makes sense. In terms of publication, it's the same thing. As a researcher, yes, the capital is publication as well. But it's not just to publish. Again, think about what it is you're saying there, because that information that you're disseminating can be impactful to people's lives. And so you really want to be thoughtful about the meaningfulness of what you're trying to get out there. I've made that mistake, so I'm not going to say I'm the best.
You're only human, right?
I'm only human. Yeah. I publish stuff based on expediency, but you cannot do this. And I know that there's pressure to get papers out and get them out as quickly as possible, but one has to find that balance.
Wow, that's powerful. That's powerful, Dr. Laing. Thank you so much for sharing with us today about your philosophy, your research, and giving that advice to aspirational, someday will be researchers. Your classroom posture of wanting to inspire more researchers really comes through. And thank you for sharing this with us today.
Thank you so much, Alex, for having me. It's been my pleasure. Thank you.
Thank you for tuning in to University of Washington School of Nursing's Voices of Nursing podcast. Join us next time as we continue to explore topics vital to nursing, health, and well-being. Until then, stay informed, stay inspired, and stay engaged. And don't forget, follow Voices of Nursing wherever you listen to your favorite podcasts so you'll get every show as soon as it's released.